All right, so let's talk about pancreas here. To talk about the location of the pancreas is located in the T12 to L3 vertebra. Okay, so for the location of pancreas, where it's located in the T12 to L3 vertebra, right? If we talk about the length of the pancreas varies between 12 to 15 centimeter. The width varies between 3 to 4 centimeter, and its thickness varies from 1.5 to 2 centimeter. Thickness is very important to remember, right? And the average weight can vary from 80 grams to 90 grams, right? Okay, so this was about some data here. Now let's come to the main portion. So for the parts of the pancreas, we have four major parts: the head, the neck, the tail, and the body. And along with the head, we study about the uncinate process, and with the body, we study something known as the tuber omentum. Okay, so the head, the uncinate process, the body with the tuber omentum, the neck, and ultimately the tail. So let's take these up one by one. Talking of the head of the pancreas, we have majorly three borders: the superior, the inferior, and the right lateral border. If you see in this diagram, this region is the head. You have the superior border, you have the inferior border, and you have the right lateral border. Okay, so the superior, the right lateral, and the inferior border. Okay, now what's related to the superior border? You can without a doubt say that the superior border is in relation with the first part of the duodenum. The right lateral border is in relation with the second part of the duodenum, and the inferior border is related to the third part of duodenum. That's what I've written here. The superior surface is related to first part of duodenum. The inferior surface is related to the third part of duodenum, and the right lateral border is related to the second part of duodenum. Okay, no doubt. Now for the surfaces, we have the one interior surface and one posterior surface. Obviously, the surface facing towards you will be the anterior surface, this which I'm shading, and the one in the back behind it will be the posterior surface, right? So to talk about the relations, the anterior surface is related with the transverse colon, and of course if there is transverse colon, it will also be related to the transverse mesocolon, right? Now if you see here, this is the head of the pancreas, this region along with the uncinate process, and here I've made the colon. So if you just extend it till here, okay, so this is how the colon will be present. Now the head of the pancreas, the anterior surface is related to the transverse colon and transverse mesocolon, and what will be in the posterior relation, will have the bile duct, the left renal vein, and of course what's the major vein on the posterior side, the inferior vena cava. Okay, if we see in this diagram right here, in the anterior relation, we have the transverse colon. I'll talk about the major relation, guys. The transverse colon in the anterior relation will also have first part of duodenum and jejunum along with superior mesenteric vessels. Okay, and on the posterior side, we'll have this major vein, which is the IVC. Here is the bile duct, and what's left? The left renal vein. Remember, you might get confused that right renal vein also passes behind the head up, but it's almost on the right lateral border, so you can't really consider it in posterior relation with the head of the pancreas. Okay, so we take the left renal vein, and you also see some accessory structures, right? The right crus of the diaphragm. Okay, and here you have the uncinate process. Now, if we talk about in detail of the uncinate process and its relations, basically, it has the double relation, right? Anteriorly, it has the superior mesenteric artery and superior mesenteric vein, and posteriorly, the major blood vessel lies the aorta. Okay, so uncinate process anteriorly, this is the uncinate process here. Anteriorly, you have the superior mesenteric artery and the vein, and on the posterior side, sorry, but this diagram is a bit out of proportion here. Actually, the aorta should be a bit here. That's why, that's how it will lie on the posterior side of the uncinate process. Okay, so for the sake of remembering, on the anterior side we have the superior mesenteric artery along with the superior mesenteric vein, of course, and on the posterior side we have the aorta. All right, so if we now move on to the neck, the relations of the neck are very easy. We've studied the formation of portal vein. Where does the portal vein form? It forms just behind the neck of the pancreas. How? From the junction of splenic vein and superior mesenteric vein. Okay, so this is the portal vein, and here will be the neck of the pancreas, right? So again, very easy relation. And for the anterior relation, we have the pylorus of stomach. Okay, and pylorus will be then continuing to merge with the first part of duodenum. So these were the relations of neck of pancreas. Okay, so now we move on to the body of pancreas. For the body, see, if you take a section of the pancreas like this, if you cut the pancreas like this and just rotate it and see, you'll see a triangular cross section. Okay, you'll see a triangular cross section of the pancreas. Now it has got majorly 3 borders and 3 surfaces. The border facing anteriorly, what it will be called as the anterior border, of course, the superior border we have here, and here lies the inferior border. Okay, now in between you'll have the surfaces. The surface facing the back will be known as the posterior surface. The surface facing in front, it's the anterior surface, or rather more correctly I should call it as supero-anterior surface. The surface is supero-anterior, and what's this surface? Inferior, or rather more correctly antero-inferior surface, yeah, or infero-anterior surface, whatever you can call it. Now if we talk about the relations here, let's take up the borders first. Okay, let's take up the borders: superior border, inferior border, and anterior border. For the superior border, you have the 3 major arteries in relation: the celiac trunk, the common hepatic artery on the which side? It will be on the right side, and the splenic artery on the left side. If you see in this diagram, here is the celiac trunk, the splenic artery towards the left, and common hepatic artery towards the right. Okay, so these are the major relations of the superior surface, or superior border rather. We're talking about the borders first. We have these relations in the superior border. Coming on to the inferior border, of course, we'll have the superior mesenteric artery and the superior mesenteric vein. And lastly, talking of the anterior border, what we'll have? The transverse mesocolon, right? Let's revise it once again. Superior border, we have 3 arteries: celiac trunk, 1 branch to the left, 1 branch to the right. Okay, and what about the inferior border now? We have the superior mesenteric artery and the superior mesenteric vein. And lastly, the anterior border facing the anterior side here, what we'll have? We'll have the transverse mesocolon running. Okay, so we're done with the borders now. Let's move on to talk about surfaces. Again, 3 surfaces: the anterior surface, the posterior surface, and the inferior surface. Now let's apply some common sense here. What lies anteriorly to the pancreas? It's of course the stomach, and in relation with stomach we have the lesser sac. So of course, what will be in relation with the anterior surface? It will be the stomach and lesser sac. What lies inferiorly to the pancreas? What will be running inferiorly to the pancreas? Think about it. It will be the colon. Basically, we can talk about the 2 flexures of colon: the duodenojejunum flexure and the splenic flexure. Splenic flexure will be formed near the spleen. Okay, we have talked about the colic impression on the spleen as well, formed due to the splenic flexure, and of course it will be on the inferior side surface, because the transverse colon is running. Okay, so the 2 flexures, the DJ flexure and the splenic flexure. Now lastly, the posterior surface, again will have some blood vessels and 1 major organ in relation, that is the kidney. Again, the kidney will be a bit bigger. Okay, we have the kidney in relation with the posterior surface. So the left kidney and the left suprarenal gland, along with it lies the aorta, the major artery, the abdominal aorta basically, and the splenic vein. Okay. uh, in the last lecture of spleen, I also talked about that the splenic vein runs behind the pancreas. Okay, so obviously it will be in the posterior relation of it. Lastly, we talk about the tail. It's the only part of the pancreas that is peritoneal, lies in the lean-or-renal ligament, the ligament joining the spleen with the left kidney. It's the mobile part and it's highly laden with aisles of Langerhans, the high beta and alpha cells. Okay. So for the relations, it's related with the hilum of the spleen and it's located between the gastric and colic impressions on the spleen. If I take you back to the slides, here is the gastric impression, here is the colic impression. Okay, so between the gastric and the colic impression lies this impression for the pancreas, basically the tail of the pancreas. Okay, so it's located in the hilum of the spleen in the lean-or-renal ligament between the gastric and colic impressions. Okay, now we come on to the arterial supply of this pancreas. So as you can see, the arterial supply is majorly the ones which I've highlighted. Here you have the celiac trunk. From the celiac trunk goes the splenic artery, and as the splenic artery progresses towards the spleen, giving off hilar branches, it gives off 3 or 4 major branches. What are those? These two pancreatic branches. More specifically, these are dorsal pancreatic branches supplying the pancreas. Then we have a big artery called arteria pancreatica magna, again supplying the body of the pancreas. And we have arteria chordae pancreatis supplying the tail. What do you mean by chordae? Chordae itself means tail. So what this artery will be supplying? The tail of the pancreas, right? And then here is the celiac trunk. From that you have the common hepatic. Common hepatic gives off a branch gastroduodenal, and gastroduodenal artery further gives off one branch known as the superior pancreatico-duodenal artery, supplying the duodenum and the pancreas as well. Now again you have two divisions, I should say. The anterior division supplying the anterior part and the posterior division. There should be a correction. They should have drawn it dotted here because this artery will be posterior to the pancreas. Same, you'll have one branch of superior mesenteric artery, but inferior pancreatico-duodenal artery, that will anastomose with the superior pancreatico-duodenal artery. The anterior branch will anastomose with the anterior branch of this, and the posterior branch will anastomose with the posterior branch. And one more relation you can establish here, where this thing is anastomosing on the right lateral border. Okay, so you can also say that on the right lateral border you have the anastomosis between the anterior and posterior divisions of superior pancreatico-duodenal artery and inferior pancreatico-duodenal artery, right? So this was about the arterial supply. Now for the venous drainage, it drains into all three veins: the portal vein, the superior mesenteric vein, and the splenic vein. Now if we talk about innervation, it is innervated by T6 to T10 nerves plus majorly the posterior vagal trunk. Anterior vagal trunk will also be supplying, but the major innervation is by the posterior vagal trunk. Okay. Now again, if we talk about some peripheral relations here and there, I've taken this from the BDC textbook. Okay, so the superior border, as we talked about, related to the first part of duodenum, but it's also related to the superior pancreatico-duodenal artery. We've seen here, what's this? This is the superior border or superior surface of head of the pancreas, and what it's related with the superior pancreatico-duodenal artery. Okay, and same goes with the inferior border or inferior surface. It will be related with the inferior pancreatico-duodenal artery. Okay, no brainer, simple. And the right lateral border, I've told you that what occurs here, anastomosis between them. Okay, so we've seen this diagram, and this diagram shows the relation of the neck of the pancreas. As I've told you, on the anterior surface of the neck we have the pylorus, and on the posterior surface of the neck of the pancreas we have the anastomo, or rather the formation of portal vein. Okay, so here you have the splenic vein, the superior mesenteric vein, they join to form the portal vein. Where it happens? On the posterior side of neck of the pancreas. Okay, so we're just proceeding towards the end of the lecture. Let's discuss some clinical aspects and various ducts of the pancreas. So majorly you have two ducts. The main pancreatic duct is known as the duct of Wirsung. Okay, it's 3 millimeter in diameter. And how will you recognize it? It's white in color. Okay, please remember it that the duct of Wirsung is white in color, and it receives various tributaries which join it at an acute angle, forming a herringbone pattern. I'll show you in this diagram. Okay, so it receives various tributaries from various parts of pancreas from the substance, and this forms a herringbone like pattern, right? So that's what it's saying here. And for the accessory pancreatic duct, it's known as the accessory pancreatic duct of Santorini. Okay, and it opens into the duodenum at the minor duodenal papilla. You guys already know about it. And the opening of the accessory duct lies cranial. Okay, you know, it's above the major duodenal papilla and ventral to the main duct. This is a very, very important point. Students usually get confused that the minor and major duodenal papilla, lie in line with each other, but it's not true. It's not true. The minor duodenal papilla, the opening, lies ventral to the opening of the main duct. Okay. Now, why we have the two ducts? The two ducts remind of the double origin of the pancreas from the dorsal and ventral pancreatic buds. Right, we'll talk about this in a minute. So the lymphatic drainage, it drains into all the pancreatico-splenic, the same lymph node in which the lymph from spleen was draining, the celiac lymph nodes, and the superior mesenteric group of lymph nodes. Right? Now talking of some clinical aspects here, carcinoma is very common in the head of the pancreas. Okay, this is a very frequently asked point where the carcinoma is most common in the head of the pancreas. Now remember, if there is a carcinoma in the head of the pancreas, where will the pressure be referred? The pressure will be referred over the posteriorly placed bile duct. Okay, what we had on the posterior surface of the head, we had the bile duct, right, which can lead to persistent obstructive jaundice. A point to remember, and the aftermaths can also be pyloric obstruction and ascites. Okay, so acute pancreatitis, inflammation of pancreas, it's also a serious disease and may be a complication of mumps. What's mumps? It's a viral disease of which part? Mumps is a viral disease of the parotid glands, and it's most common in children. Okay, so now if there is inflammation, will also be pancreatic pain, and it's felt in the back as well as the front of abdomen due to various relations around so many structures. Okay, and pancreatitis results in the collection of fluids in the lesser sac. So if there is a fluid collection in the lesser sac, that can also result in pancreatitis. Okay, next up we have annular pancreas. I'll talk about this in a minute, but let's see the referred pain from pancreatitis, where the pain is referred. So the pain is referred to the epigastrium region, okay, 1, and to the lower thoracic vertebrae, 2. Where is the pain from pancreatitis referred? It's referred to the epigastrium and on the lower thoracic vertebrae, right, due to the inflammation of soft tissues of retroperitoneum. Now, superior mesenteric vessels, where they lie? They lie on the posterior relation of head of the pancreas and in anterior relation of the uncinate process, right, lying behind the body of pancreas and in front of its uncinate process. Okay, so if there is pancreatitis, it may cause inflammatory aneurysm of the artery or thrombosis of the vein. There can be aneurysm of the artery and clot in the vein, right? Now, we've previously studied the arterial supply of the pancreas and know how profuse it is. So it's very prone to hemorrhage if there is a blow in the pancreatic region, and if there is hemorrhage, the blood can also enter the bare area of the liver in front of the falciform ligament. It runs in front or forward of the falciform ligament and may reach around the umbilicus, causing umbilical pain as well. Right. So the same point here. Sometimes the fluid resulting from pancreatic inflammation may collect in the lesser sac of the peritoneum, and this condition is known as a pseudocyst, a false cyst. Right. And the pancreatic recession, remember, only section of the head and neck is possible. You can't remove the tail. Why? Because it has a huge quantity of Isles of Langerhans. Okay, so let's talk more about accessory pancreatic duct here. How the accessory pancreatic duct is formed. If you follow it from the minor duodenal papilla, in this diagram, if you see here, we have the minor duodenal papilla, which is cranial and ventral to the major duodenal papilla. Right. Now, if we follow it, okay, we can see a branching point here, right, from which it divides into two branches. One branch communicates with the pancreatic duct. Can you see? Please, can you see here? One branch is communicating with the pancreatic duct, and the other branch runs in anterior relation to the pancreatic duct and goes into the substance of the uncinate process. Right. One branch communicates with the pancreatic duct and the other runs anteriorly over the pancreatic duct to go in the substance of uncinate process. Alright. So the one branch continues to the left through the head of the pancreas and may connect with the pancreatic duct, and the second branch descends to the lower part anterior to the pancreatic duct and ends in the uncinate process. Okay. Now again, the main and accessory pancreatic ducts usually communicate. We have seen the first branch joins with the pancreatic duct, and the presence of these two ducts reflect the embryological origin of the pancreas from two buds, the ventral and the dorsal bud, Okay, so talking of the last point here, we have annular pancreas. Okay, also we came across it here. So what basically is annular pancreas? It's a developmental anomaly in which the ventral bud becomes bifid. Okay, where a ring of pancreatic tissue surrounds and obstructs the duodenum. Let's see how. So the dorsal bud forms the major part of the pancreas, mostly the head, the neck and the body. But the ventral bud rotates around the bile duct, which is in the posterior relation, and forms the part of the head and uncinate process. Now, if this ventral bud becomes bifid, okay, divides into two, what will happen? Duodenum lies here, the second part of the duodenum. It will cover the duodenum from all around. Okay, and as the pancreas grows, it will press upon it, causing what? Duodenal obstruction basically. So, if the ventral bud splits and becomes bifid, the two segments may encircle the duodenum and it gets constricted. Now, what are the complications? After birth, the child may fail to thrive and may vomit due to poor gastric emptying, of course, and sometimes it's diagnosed in utero by ultrasound scanning. Okay, and the obstruction of duodenum may prevent the fetus from swallowing through amniotic fluid, which what will happen if there is an obstruction in duodenum? The fetus can't swallow substances from the amniotic fluid. So what will happen? Those substances will remain in the amniotic fluid, increasing its volume due time. Okay, and this condition is known as polyhydramnios. Right, polyhydramnios. What's this? It's overall increase in amniotic fluid. Why? Because the fetus can't swallow enough amniotic fluid. Right. The obstruction of duodenum may prevent the fetus from swallowing enough amniotic fluid. So this was all about pancreas here. Thank you very much.